palliative care. She's also the head of unit at the palliative care unit in Kenyatta National Hospital. She also chairs the ethics committee within the hospital, and she has a vast experience in pain and palliative care, and she has been an asset to patients who require this care. Without further ado, allow me to also introduce our topic for the day, and we shall be talking about ethical imperative of patient autonomy. So why is patient autonomy important? It is important because it emphasizes the patient's right to make informed choices about their own medical care, which aligns with their values and preferences. It also ensures that patients actively participate in their treatment plans rather than to become passive recipients of this care. So to give us more insight on this topic, let me welcome Dr. Nafula to take us through the session. Welcome, Dr.
Thank you. Let me share my presentation.
As presentation, maybe I can address some of the concerns I'm seeing in the chat box already about CPD points not being given for the last sessions. I think we shall look into this with the technical team that handles the issue of CPDs. You can also share your email in the chat box, and we shall be able to get back to you. Dr. Nafula, we are waiting for you.
Good afternoon. Welcome to today's session. We are going to be considering the ethical imperative of patient autonomy. Autonomy is one of the four cardinal ethical principles, and this afternoon we want to see how this principle of autonomy relates with the other ethical principles. So medical ethics is based on four cardinal principles, namely autonomy, beneficence,
Dr. Nafula, sorry.
autonomy, self-rule, or the
Dr.
ability.
Nafula, sorry to interrupt. I think you're far away from your microphone. You're not well audible.
Okay. Sorry, I'm just trying to adjust my volume. Just a minute.
Now we can hear you.
So medical ethics is based on four cardinal principles, namely autonomy, beneficence, non-maleficence, and justice. Autonomy is self-rule, or the ability of one to make their own decisions, and we look at it in detail. Beneficence is where we act in the best interest of the patient. So whatever we prescribe should be meant to give more benefit than risk. Non-maleficence reminds us to be mindful of on our patients, so it is closely related to non-maleficence. And the principle of justice looks at how we can have equitable treatment in the healthcare space. Autonomy comes from a Greek word which means auto. No, and nomos. Autos means self and nomos means slow. So autonomy is self-rule. It is therefore the ability of an individual to make meaningful choices for themselves, and it's embedded in the human rights and patient rights that one has a right to make informed choices about their medical care, and it is the very core of patient-centered care. So patient-centered care is where we focus on the patient. We want to know what are the values of the patient, what is important to the patient, and how can we involve our patient in decision making. Autonomy has sorry for the hiccups. We are trying to sort it out. Good afternoon. Welcome to today's session. We are going to be considering the ethical imperative of patient autonomy. Autonomy is one of the four cardinal ethical principles, and this afternoon we want to see how this principle of autonomy relates with the other ethical principles. So, medical ethics is based on four cardinal principles, namely autonomy, beneficence, non-maleficence, and justice. Autonomy is self-rule, or the ability of one to make their own decisions, and we look at it in detail. Beneficence is where we act in the best interest of the patient. So whatever we prescribe should be meant to give more benefit than risk. Non-maleficence reminds us to be mindful of the impact we have on our patients, so it is closely related to non-maleficence. And the principle of justice looks at how we can have equitable treatment in the healthcare space. Autonomy comes from a Greek word which means autos, no, and nomos. Autos means self and nomos means slow. So autonomy is self-rule. It is therefore the ability of an individual to make meaningful choices for themselves, and it's embedded in the human rights and patient rights that one has a right to make informed choices about their medical care, and it is the very core of patient-centered care. So patient-centered care is where we focus on the patient. We want to know what are the values of the patient, what is important to the patient, and how can we involve our patient in decision making. Autonomy has four key features. The first one is informed decision making. So this is where a patient has enough information that they are able to make a decision that is good for themselves. So this information is given to them in a language they can understand, in a way they can understand, in very simple terms, so that when they make a decision for treatment or against treatment, they have all the information that they need. Voluntariness, no coercion. So any decision that an individual makes about their healthcare should not be coerced or due to threats that they are receiving, that failure to receive this treatment will result in your death, but rather the patient makes a voluntary decision for themselves. The other thing that we consider when assessing autonomy is the capacity and competence of the individual. Do they have the mental capability to understand what we are telling them? Are they able to comprehend, and are they able to make a decision? And competence is embedded in the law. Does the law allow you to make a decision for yourself? Then authenticity is aligned with the specific individual values of the patient. So this means what is important to me as an individual, me as Esther, when I'm making a decision. What are some of the things that will influence my decision? What are some of the things that are important to me? This could be my religion, my culture, my profession, my financial status. So all these things also play a role when it comes to determining the autonomy of the patient or the decision that the patient is going to lean towards making. I would like us to take a few minutes to discuss the history of autonomy so that we understand how we got to this space of patient-centered care and the patient deciding what is good for them. So before 1970s, medical practice was very paternalistic. The doctor knew everything. The physician made decisions on behalf of the patient. So it was the era of trust me, I'm a doctor. You need this procedure, it is good for you, it's going to save your life. So the decision was made for and on behalf of the patient. The patient had no say. You come in sick, this is the treatment we recommend, that is the treatment you're going to receive. We have our Hippocratic Oath. Our Hippocratic Oath is what we take as doctors to uphold the highest standards of medical care. And I will paraphrase from that oath. When translated in English, the original oath, of course, was written in Greek. So there is a paragraph that talks about what we will do for our patients. And we promise, I will do no harm nor injustice to my patients. So the first principle is do no harm. When we look at these experiments that were being carried out in these concentration camps, most of them were doing harm to the subjects, and the subjects were not even aware. And some of this resulted in death. Now, when we shift from World War II, came first the Nuremberg Code of 1947, where it was emphasized that a human subject participating in an experiment needed to give voluntary consent. So they are not to be coerced with incentives, money, but you give voluntary consent to participate in an experiment. And the consenting process involves being given full information to understand the risks, the harms, the benefits of participating in that experiment. The second aspect was to avoid unnecessary suffering. So an experiment needed to be evaluated whether it is going to cause suffering to the subjects, and is that suffering necessary? Is there another way that we can do this experiment to get the results that we want? If we are doing a clinical trial on efficacy of medication, must it be given to human subjects, or can it be given to rats in a lab and we can still be able to obtain the same results? Then the third aspect was justification of experiments. Experiments needed to be justified. So an experiment was only valuable if it was going to give potential benefits to the society. So experiments that are not going to benefit a wider majority of people should not really be conducted. 1975, after the Nuremberg Code, in 1975, there was the Helsinki Declaration by the World Medical Association. And again, it was looking at ethical principles for medical research involving human subjects. And this is embedded in the principle of do no harm, non-maleficence. So experiments with human subjects, apart from us just ensuring that the subject has consented, that the experiment is beneficial, we are not going to cause unnecessary suffering, how do we ensure that there is no harm coming to the subjects? Because again, we could declare that we are going to do these things, but there needs to be an oversight by a committee. So research ethics committees were developed in mid-1960s. That is when they started reviewing research around human subjects. And in 1975, following the Helsinki Declaration, it is now mandatory that any research that involves human subjects must be approved by a research ethics committee. And of course, the committees have laws that govern how they are formed, who constitutes the committee, and the committee has individuals who have competence to assess the ethics of the research. Now, the focus again is on autonomy, that anyone participating in a research should be aware of the harms of that research, should be aware of the risks, and should give willing permission, should be voluntarily taking part in an experiment. back to the 1800s where it was very paternalistic. So the doctor was always right. They had professional authority. Decisions were made by the physician, and all the patient had to say was yes. So the patient had no say on whether they were receiving treatment or not, how the treatment was going to be given. And of course, we know a lot of unethical things happened in that era. Now, before we get to the 20th century, we need to consider that a lot of invasive medical procedures were being done without consent. They were being done without any explanation to the patient. The patient was only told this is right for you. So from 1914, Justice Benjamin Cardozo in the US justified the right of every individual of sound mind to determine what should be done to his or her own body. So a lot of consent for surgery began around that time, that a patient needed to understand this is the kind of procedure that I need, and then would consent to have the procedure done. Around the 1930s, mechanical ventilation, cardiopulmonary resuscitation were introduced into medical practice where patients' lives could be prolonged using mechanical ventilation and life support machines, and the patients also had a right to decide for themselves which interventions they were going to get. Around the 1960s, patients now had a right to accept or refuse these therapies and started off with law in the state of Illinois. So again, the patient had a right and a space to choose. Yes, I want this treatment. No, I don't want this. Following all this legislation, in the 1970s, uh, Beauchamp and Chadres published a lot of books on principles of biomedical ethics, and this is when the terms of autonomy as a core principle of medical ethics began to be discussed a lot and researched a lot, and this was influenced by the civil rights and legal cases. And the emphasis this afternoon is that any individual of sound mind has a right to decide about their medical care. They have a right to decide what happens to their bodies, just like Justice Cardozo ruled in 1914. Now, autonomy brings a lot of conflict in medical practice, and it is often conflicting with the principle of beneficence. So before we delve too much into autonomy, I would like us to look at the principle of beneficence, where beneficence is acting in the patient's best interest. So we often have to determine what is in the best interest of the patient. It is motivated by us preventing harm, doing no harm to our patients, but making a decision that is going to improve the well-being of the patient and result in the best outcome for the patient. So beneficence is linked to professional responsibility. Autonomy is upon the individual receiving the treatment, but beneficence is upon the professionals who are offering care to determine what is in the best interest of the patient. Now, considering the best interest of the patient doing good, it often brings a dilemma because sometimes patients make decisions that as healthcare providers we consider not to be in their best interest. Yet, we still have to respect their right of autonomy to make decisions about their own healthcare. So how do we determine what is the best interest of the patient? So we first look at what is the intention of the intervention that we are giving. Is that intervention going to cause harm or is it going to cause benefit to the patient? We need to look at what is the prognosis of the patient. What are we expecting from the interventions that we are giving? What is the likely outcome with the intervention or without the intervention? And then, of course, the biggest question is usually what would your colleague do in a similar situation? So if we have the same training, we're medical doctors, a patient has come to us from a road accident, the patient is bleeding. What is the rational thing to do? Remember, ethics is about doing what is morally right, what is morally acceptable. So determining the best interest of the patient helps us to also see whether we respect the autonomy of the patient or whether we override the autonomy of the patient. So in autonomy, when we compare these two principles, the patient decides. So the patient decides what is best for them, and we need to uphold the decision of the patient. And that the outcome does not matter. For beneficence, the provider decides what is best for the patient, and usually it is highly defined by the outcome that we are expecting. I would like to give a case of a patient so that we use it to think through the aspects of autonomy versus beneficence, and to see whether in such situations do we always uphold the autonomy of the patient or not. So a 32-year-old female patient presents with a diagnosis of postpartum cardiomyopathy, right heart failure, left breast mastitis, and gangrene of her toes and fingers. She's a para 3 plus 0, admitted for 1 month post-delivery with bilateral lower limb swelling, a left breast wound, and hypotension. She was noted to have breast abscess and mastitis. The abscess was drained. She was started on antibiotics. She then developed cardiogenic shock, was managed at a peripheral facility and referred to KNH, which is highest referral hospital. So the patient, while in the ward, develops gangrene of the toes and fingers associated with severe pain. Bilateral lower limb Doppler is done. It shows no DVT or venous insufficiency. A CT pulmonary angio shows cardiomegaly with hepatic congestion and right heart failure, but no signs of thromboembolism. The patient is started on analgesics, morphine, lactulose, prednisone, amitriptyline, and has now completed her antibiotics. It is suggested that she gets an amputation of her gangrenous toes and fingers. The patient declines and opts for discharge against medical advice. And before she declines, it has been explained to her the risks and benefits of the procedure, but she says she does not want an amputation. Remember, she's 32 years, so she's sound of mind to make this decision. So cases like this, the biggest question is, do we respect the patient's autonomy and give them a form to sign that they can be discharged against medical advice? Or do we insist and give her the treatment that would be life-saving, because staying with gangrenous toes and fingers could result in more complications and eventually death for the patient? So in that case, autonomy, the principle of autonomy would dictate that we respect her choice. We say that this patient is sound of mind, she's competent to make a decision, and she has decided that she does not want an amputation. So we will discharge her against medical advice, and if she dies, it is okay. We've respected her choice. Beneficence would say we have to save her life through intervention. So we have to try and convince her to sign for us consent for the amputation. And if she does not sign the consent, we have to look at what other options do we have to mandate her or to coerce her into getting an amputation to save her life. So the tension is usually between respecting the choice of the patient and saving the life of the patient. That even when that choice that a patient is making seems irrational, this choice could lead to their death, do we respect that choice, or do we push for the choice of saving the life of the patient through a medical intervention? Paternalism would dictate that the doctor is right. Trust me, I'm a doctor. We need to save you food. We need to amputate your toes. We need to amputate your fingers because they're gangrenous and this could result in death. Now, unfortunately, we are not in that era. We are in an era of patient-centered care. In the era of patient-centered care, the approach involves empowering patients to take an active role in their care, and it necessitates that healthcare professionals have strong communication skills and effectively address the patient's needs. As you can see on the picture on the right of the screen, the doctor literally has a paper and a pen. is probably drawing a diagram. You have to explain to this 32-year-old female patient to understand, what does gangrene mean? How does it come about? How does this illness come about? What are the complications? So it is not just telling the patient this is good for you. Additionally, we have to consider what the needs of the patients are. So is the patient concerned about missing toes and fingers? Are they concerned about their physical comfort? What is the emotional well-being of this patient? This is someone who is postpartum, has spent over 2 months in hospital after delivery. So there might be other concerns apart from just the illness, apart from the gangrene. So patient-centered care helps us to look at what the patient and family preferences are, what their values are, their culture, traditions, socioeconomic conditions. So the patient has to participate in decision making. The patient has to participate in decision making. The patient has to be content about the decision, and there is room for questions and answers. The patient will ask you a lot of things so that they're able to understand, so that whatever decision they make, the patient is fully convinced that is the best decision for them. So the aim of respecting a patient's autonomy is so that we are able to have a shared decision. We are able to negotiate between the doctor and the patient, and the decision that is made is in the best interest of the patient. It is beneficent to the patient. The decision that is made will do no harm. It will do good for the patient. Why should we respect the autonomy of patients? First, it's a moral justification. It is morally right for us to respect an individual, to respect their decision, to respect even their ability to make a decision and stick by it. It is also a legal requirement. So the law, it's deeply embedded in our law that we need to uphold a patient's right to self-determination, so that we are able to respect the decision that the patient makes, that we recognize that patient has a right to make decisions about their health, even if those decisions differ from what we as healthcare providers might recommend. So it also promotes patient-centered care, which means that we involve our patients in decision making. This improves the trust that the patient has in us. It improves the satisfaction levels with healthcare and improves the outcome of the patient. Because when the patient understands the importance of a treatment and chooses to have that treatment and they agree with that plan, they are more likely to adhere to it, leading to better health outcomes than when a patient does not want treatment. We are forcing them to get that treatment. Once they get the treatment and are discharged from our institution, we never see or hear from them again. Let's look at some of the legal and professional grounds for autonomy. So the legal grounds for autonomy in our healthcare systems stem from the principles of informed consent and the right to privacy, which are recognized as fundamental rights in human rights charter. So they are often upheld through laws and regulations, and these laws could be at the national level. They could also be at the global level and at the institutional levels. So this respects the individual rights to make decisions about their health care. So informed consent is actually the cornerstone of patient autonomy, where it mandates that as healthcare providers, we furnish our patients with sufficient information about the proposed treatment benefits, risks, alternatives, consequences, so that the patient voluntarily makes a decision to go, to undergo, or to forfeit the treatment that we are prescribing. So we have a lot of legal frameworks. So many jurisdictions have enacted laws and regulations that codify the patient's rights, including their right to autonomy and informed consent. So some legislation is very specific in some areas about situations where autonomy is paramount, like in making end-of-life decisions, giving consent for surgical procedures, And then the codes of ethics, just beyond the legal aspects, autonomy is a fundamental ethical principle in healthcare. So we need to respect the patient's value, beliefs, and preferences when they make decisions, and we need to look at how their autonomy overrides with the other ethical principles. And then again, our institutional policies need to consider the ethical principles. We cannot have institutional policies that undermine the principles of medical or healthcare practice. So in Kenya, we've not been left behind. The Kenya National Patients' Rights Charter of 2013 gives the patients a right to refuse treatment. So it states, and I will read it verbatim. Any person, patient, or client may refuse, withdraw, or withhold treatment, and such refusal shall be documented in writing by the medical service provider and in the presence of an independent witness, provided that such refusal, withdrawal, or withholding does not create an immediate danger to the patient or the health of others, and provided further that the consciousness and competency of the person has been taken into account. That is a very loaded statement about the right to refuse treatment. So you see, the first part says that you as a person have a right to refuse, withdraw, or withhold treatment. The second part says this refusal should be documented by the medical service provider in the presence of an independent witness. And then it now gives conditions. That refusal, withdrawal, or withholding should not create an immediate danger to the patient. So their refusal of treatment is not going to result in their death, for example. It is not going to endanger the health of others. You don't have a contagious illness and you want to refuse treatment. And then the consciousness and competency of that person should be taken into account. Do you have the capacity, and do you have the competence to make the decision? We will look at those two terms in the next few slides. The Health Act of 2017 also mandates that healthcare providers should obtain a patient's informed consent before providing any health service, except in specified emergency situations, lack of capacity to consent with no authorized representative, or when public health necessitates intervention. So it is closely linked to the Patient Rights Charter that you have a right to decide for yourself about your treatment, except when it's an emergency situation, you lack capacity, there is no one to consent on your behalf, or it is a public health crisis. So that brings us to the next aspect of when do we override the patient's autonomy. So yes, you have a right to decide for yourself, but sometimes we also look at beneficence. Where beneficence is paramount, then beneficence will take a lead over autonomy. So some benefits of autonomy, we've already talked about it. It improves compliance and communication between the healthcare team and the patient. It reduces risks of litigation. It supports dignity and self-determination. Now, our own law in Kenya has already answered this question, that when can autonomy be overridden? So first is when there is lack of capacity. So a patient who is in a coma or lacks the capacity to make a decision as is defined by the law, then their autonomy can be overridden. The decision that is made should be in the best interest of the patient. And remember, for beneficence, we say the decision maker is the healthcare provider. So when the patient lacks capacity, then we need to decide what is in the best interest of the patient. When there's a risk to public health, it's an infection, it's a pandemic, it is something contagious, your autonomy does not matter. If a patient has an infectious disease that could result in a pandemic and they've come to hospital and they decline treatment, we cannot respect their wish to decline treatment because it is for the interest of others. Remember, our Hippocratic oath said we are going to do no harm nor injustice to our patients, and we also serve the bigger population, not just the patient. Then when it is a risk to others or to themselves, so in psychiatric situations where it's an emergency, also the patients are treated without consent. Because where someone risks harming themselves or harming someone else, then we really have to consider whether their autonomy is going to be paramount to the benefit of them receiving treatment. Now, capacity and competence are the two terms that I want to delve into now. So, assessing capacity of a patient, how do we know that someone has capacity to make decisions? So first, the patient must be able to understand the information we are giving to them. So they are able to comprehend what you're telling them, the nature of the decision that needs to be made. These treatment options you're talking about, potential outcomes, the patient can be able to comprehend what you're saying. Then they should be able to retain that information. If you ask them to repeat to you after a couple of days, they understood what you are saying. So this capacity is emphasized by communication. Communication is a two-way channel. It's not just me speaking and the patient listening, but it is us engaging so that I know what the patient might have understood, and if there's a misconception, we are able to clear it. So the patient recognizes how the decision affects themselves, the potential benefits and risks of that decision, and is able to weigh the options. So this means you've also explained the options to the patient, and then they're able to reason with you to evaluate the options in a logical way. And they're able to express their choice in a way that others can understand. So I'm not just saying I don't want that treatment. I understand, like the case that we have used, I'm 32 years, I'm postpartum. I understand that I have cardiomyopathy. I understand that I have just been treated for a severe infection. I understand that I need amputation for my toes and fingers because they are gangrenous. I understand that gangrene means these tissues are dead. And I'm making a decision not to go through with the surgery. And maybe my reasons for making the decision can be given. I could say I don't want this surgery because of 1, 2, 3. So capacity changes over time. So capacity can be affected by mental health conditions like dementia and schizophrenia. It can be affected by a physical illness where someone is incapacitated, someone is in a coma, someone is so sick that they are not able to think clearly. Some medications impair cognitive function, so they will reduce the capacity. Substance abuse like alcohol, drugs of abuse, they also interfere with the capacity of the patient. So when we are looking at consent, we have to assess the capacity of the patient to make a decision. So we have to assess that capacity so that we ensure that a patient who lacks capacity is not making decisions that will be harmful to them. And then the one who has capacity, we recognize and respect their autonomy that they are able to decide. And then we provide them with the necessary support to make a decision. And then we also have to consider what does the law say when someone lacks capacity? Who is their designated medical proxy? In our jurisdiction, how does that go? Do we take the next of kin to decide for us? And how do we also ensure that this surrogate decision maker or medical proxy is actually making the best decision for the patient? So we'll always fall back to beneficence. What is in the best interest of the? Now, capacity, I've mentioned, changes over time. So capacity again depends on the physical, cognitive, and emotional effects of illness on someone. And for a child, children, their capacity develops with time. So a child of 10 years might actually have capacity. Because remember, capacity, we say it is about you understanding the information we're giving you, being able to think logically, and being able to make a decision. So capacity, children do have capacity. Now, where the difference comes is competence. Competence is now your legal ability to make a decision. So these terms are not interchangeable. Competence is about now your legal ability to make decisions. So, for example, in Kenya, decisions are made by adults of sound mind and they are upheld. So a child, whereas a child might have capacity to understand what you're telling them, they might have capacity to understand this is my illness, this is what I'm suffering from, this is the treatment options, this is the treatment I would prefer. They are not competent to make a decision. So they cannot make decisions about their healthcare because the law does not allow them to make a decision. So first we look at capacity, and then now we look at the competence. And again, where there is doubts or concerns, we need to be able to address it legally or address it through our hospital ethics committees so that we are able to support a decision that is in the best interest of our patient. Then the proportionality. What is the potential harm versus benefit of the intervention? And of course, we need open communication and justification. Remember again, when we are overriding autonomy, personalism takes over. So this involves overriding autonomy for the individual's own good. So for a psychiatric patient, sometimes we have psychiatric patients who have capacity. So they are sound of mind. They are not incapacitated by their illness. They can tell the difference between right and wrong. An example is a recent case in the UK where a judge ruled that a patient should not be admitted against her will because she tried to self-harm herself, and the family tried to admit her against her wishes. And the court ruled that she has capacity. She can decide what is good for herself. So she's a danger to herself because she's suicidal. But now the court says we respect her autonomy. So again, the decision depends on the context and the risk. You have to look at the risk. So in this case, the judge was deciding that there's potential for her to harm herself, but since she might not harm anyone else, let us respect her autonomy. Someone else might argue, for example, if you want to commit suicide and you have a gun, you could end up, your stray bullet could end up killing someone else except you. So we have to really balance. It's a very delicate balance and it's not an easy discussion most of the time. So it often results in an ethical dilemma that would need now for us to weigh and see. Do we go with benefits, beneficence, best interest? Do we go with your right as an individual to yourself? So again, we have to look at proportionality. So when we are overriding autonomy, we use the least restrictive means possible. So that means that we give treatment, but we are not, for example, going to tie up a patient so that we can treat them. So again, we override only when it's necessary and justified, and we need to respect residual patient. Now to summarize, autonomy is a fundamental ethical principle. It is actually the foundation of ethics because it looks at the person's right to make their own informed decision about their healthcare, free from coercion or undue influence. It also recognizes the individual's capacity to determine what is good for them based on their values and their beliefs, and we should be able to respect this at all times. So respect the patient's right when they have capacity to refuse or accept treatment, and remember that it has limitations. So where the decision is going to cause harm to the patient or harm to others, then the principle of beneficence will take over. We look at what is in the best interest of the patient and others. So we try to respect autonomy as much as possible. In some circumstances, we have to override, and it needs proper justification why we are overriding an individual's autonomy. It must also be balanced with the beneficence and other principles and other our moral duty to care. So the conflicts do arise. A patient might refuse a life-saving treatment that a physician believes is necessary. So we need to remember that we need to give consideration. We need to give consideration to see which decision is in the best interest of the patient. and which decision will result in less harm to the patient. So overall, we give the option to the patient to make decisions about their healthcare. We support the decision as much as possible. And remember, we support that decision by giving them accurate, timely information in a simple manner that they can understand. And then we are able to respect the decision that they make. Lastly, the principle of autonomy also dictates that we respect the individual's decision, that sometimes a patient might make a decision that might result in their death. So sometimes we are mandated to respect the decision of the patient. Thank you so much for your attention. These are some of the references that were used in preparing this presentation. We will now move to the Q&A session. Thank you.
Thank you, Dr. Mufula. That was quite an insightful discussion. I'd like to just apologize to our participants for the low sound quality. I think Dr. Nafula's end was having some technical issues that we were not able to resolve, but we are hoping that you are able to catch a good part of the discussion. So our key aspects from the discussion on patient autonomy is informed consent, very important, that a patient has a right to refuse treatment, even when it is recommended in good faith, as long as they have the capacity to understand the implications of their decisions. There's the issue of self-governance, that it aligns with personal values, beliefs, and preferences. There's the aspect of respect for patient values, that they don't have to agree with us even when we have the best intentions. And it does not speak about the quality of care you're giving. It's just their right to choose. So there is also enhanced patient-provider relationship, which is fostered by trust and open communication between the two parties. There are also improved outcomes, interestingly, because patients are more likely to adhere to treatment plans when they realize that we are actually respecting their beliefs. And of course, there's the issue of reduced litigation risks, which is very important, especially in the age we are living in. And I'd like to now open the floor to some of the questions that we have received in our Q&A box. One of the questions is, who is the independent witness when the patient refuses treatment? Is it the patient's relative or another medical personnel within the facility? Maybe I can take 2 or 3 and then I'll leave you, Daktari, to respond to them. There's a question about the GILIC's competence. Is it applicable in Kenya? And there's another one on in family planning, you get that relatives want to decide for a client a method to use, especially when mentally challenged, and you find that the patient doesn't want. How do you go about it? Maybe, Daktari, we can pick those 3 as we continue to receive more.
Okay, so sorry for the sound challenges. Now, the first issue, the independent witness here, it is a healthcare provider, medical personnel within the facility. So it is recommended that the independent person is someone who is not within the team that is treating the patient. So if our patient, like the example we used is a patient who is declining surgery, then we can pick another healthcare provider from a different department to be our witness, that the patient actually understands and is declining treatment. Because the issue here is when it comes to declining treatment, is ensuring that the patient actually has understood the implications of their decision. So having an independent person is trying to ensure that the patient actually understands what you are trying to communicate and has made a sound decision for themselves to decline treatment. The issue of GILIC's competence, it's not applicable in Kenya because it is not in our jurisdiction. So GILIC's competence is where children 16 and below can be given an opportunity to consent for their treatment. So in Kenya, as I mentioned in the presentation, children have capacity. Capacity means they can understand what you're telling them. They can understand about their medical condition, about the treatment, but they cannot make a decision about their treatment. So in Kenya, the decision still has to be made by a parent or a legal guardian. So if a procedure is needed, the consent has to be given by a parent or a legal guardian. Stella, back to you.
Thank you, Daktari. I'll take a few more. There's one here that asks, in Kenya, at what age are children considered autonomous to make decisions? There's also one about what is the difference between capacity and competence in the case of a child. I think you have answered that. So maybe you can respond to the age where a child is considered autonomous to make a decision.
It's the age where you are an adult. So 18 and above is where you can make decisions for yourself. That is according to the law of Kenya. Again, children don't consent for medical procedures.
Thank you, Daktari.
Oh yeah, so again, yeah, the difference between the competence and capacity. Capacity is about your ability to understand the information we are giving. So children can have that capacity, but now competence is the law allowing you to make a decision for yourself. So they go together, the ability to make a decision and then the legal right. So again, we have adults who are considered incompetent by the law, that they are not competent to make a decision. Like someone who is maybe having mental incapacitation cannot be competent to make a decision. Thank you.
Thank you, Daktari. There's one here from a senior. What happens with faith-based decisions? For example, the issue of blood transfusion for an adult or a child patient. How do you exonerate the doctor? Back to you, Daktari.
Yeah, so remember our Health Act of 2017 and our Kenya Patients' Rights Charter allows a patient to make a decision to refuse or accept treatment. So the principle is the same, to ensure that you've given the patient the correct information. They have understood the implications of refusing, for example, a transfusion, and you're supposed to offer alternatives to the care. So now this law applies in situations where you are able to make the decision, because you remember in the Health Act, it says, except in situations of maybe emergency, public health concerns. So there are some situations that might not allow the patient to decide for themselves. In that case, we act in the best interest of the patient. But where a patient has capacity, competence, and is able to decide, then we are mandated to respect their autonomy for the decision they've made. So autonomy actually dictates that we respect the decision of the patient if we have done the bit of explaining to them, they've understood, we've given them alternatives, and they still make a decision to reject treatment. It's within their rights. Now, today we were talking mostly about adults. In the space of children, the law protects children. So when it comes to children, then the decision that is made needs to be in the best interest of the child. So it has to be discussed and agreed what is in the best interest of the child, to respect what the parents are requesting or to give treatment. Remember, autonomy and beneficence go together, and it's not really a conflict, but most of the time, the decision that is made has to be in the best interest of the patient. Thank you.
Thank you, Daktari. Just to remind our participants that we've been speaking a lot about the patient's right and patient-centered care. And I think this issue of patient autonomy is something that we are still trying to adjust to in the country. So I can take a couple more questions. I can see one here. Do you use the principle of emancipated minors in Kenya? And then there's one about comprehension. At what point are we sure that a patient has comprehended the information in order to make a decision to refuse or accept the treatment? Can we measure comprehension? Maybe you can take those to Dr. Nafula.
So I think the issue of emancipation violence in Kenya only happens in the reproductive health space for specific issues of contraception, teenage pregnancies. So it is not for every child, because there is really no that allows emancipation. So within the reproductive health space, they have some criteria and some guidelines of how to handle situations of contraception, teenage pregnancies, teenage mothers. So that is the space that has that provision. Stella, the next question was? Sorry.
The next one was about comprehension. At what point are we sure?
Yes, are we sure the patient has comprehended?
Yes. Maybe I can just add one that seems to be related to that one, of adults making decisions while drunk. And then there's one about the doctor's rights. When can a doctor decline to treat a patient?
Okay. So, first of all, anyone who is intoxicated by alcohol or any drugs that alter their mental health state, the law considers them incompetent. So they should not be making decisions. By virtue that someone is intoxicated, they are already incompetent to decide for themselves. So situations of an intoxicated adult declining treatment, those are the exceptions where we override their autonomy because they are not in the correct frame of mind to make decisions. Now, at what point we decide that a patient can decline treatment? So the discussions are many. It is not just one sitting. You see, even our own law says you need an independent witness. So you probably need a colleague to ascertain that the patient has actually understood. Because, you know, sometimes we use complex language, the patient has not even understood what they're declining. So at the point when we are satisfied that this patient understands the diagnosis, the treatment we are offering, they understand the implications of rejecting treatment. At that point is when you can say now, we are going to respect their decision. And again, remember, some patients decline treatment, but their health condition is risky. So they can decline treatment, go outside the hospital, collapse and die. There you have not met your moral obligation as a healthcare provider. Those are situations where the law has allowed you to override the patient's autonomy, where their decision is going to, you know, kill them. It's sort of an emergency situation. So we have to consider all those things. I think I've responded to all the questions.
Yes, you have. In the interest of time, maybe I can just pick one more, the last question. And it's about situations where a patient has an advance directive. Is the patient's autonomy considered in an emergency situation where a patient has a medical directive? And I think this should be in the context of what applies locally.
Okay, now we don't have law for advance directive yet, but the countries that have a legal framework. So advance directives are decisions that are made in advance about your healthcare. So advance directives are applicable for chronic illnesses, not emergencies. When you look at an advance directive form, some of them even specify that in the event that I have an incurable illness, I have multiple organ failure, I have Alzheimer's. So advanced directives are specific for chronic irreversible illnesses. So that patient with dementia, if they get a heart attack, we might still resuscitate them based on what the medical proxy will decide. Because now you see a myocardial infarction is an emergency. It is not a chronic progressive disease. Because advanced directives are basically to be used in the space of end of life care. This is chronic illnesses that are going to result in death. So in that situation, we respect the decision of the patient. When there's another illness that is not a life-limiting progressive illness, then the medical proxy, that's why the advanced care planning has the area of us choosing a medical proxy. Now the medical proxy will decide what they think is in the best interest of the patient. And then now we respect the wishes of the proxy. If there is no proxy, again, it's healthcare providers now to decide this patient has gotten a myocardial infarction in the background of dementia. What do we do about the myocardial infarction?
Thank you, Dr. Nafula. I see the questions that are in the Q&A box, and there are quite a number. Some of them are related to previously responded to queries. But in the interest of time, I think we will now end the session. But Daktari, from the attendance and the kind of questions we are getting, I think we need to reschedule another such presentation. It was quite insightful. And I can see a lot of people saying that they have learned quite a lot. I'm also seeing some concerns on CPD points, and I think our technical team has picked up on that, and I hope they will be able to resolve that. Otherwise, at this point, I just want to thank all of you for your active participations. Apologies once again for the technical issue of sound, and we hope it will not happen again next time. You can also write to us through the emails where you registered on topics that you would like us to address or discuss. And at this point, let me just end the session and thank you. Have a lovely afternoon.
Thank you.